So let's see my disclosures. As Franziska Eckert already said, and I'm quite glad that we have more or less, because I was a bit afraid that she will present a lot of clinical trials that I didn't find, but we have the same conclusions, that there's only sparse clinical data on checkpoint inhibition and hyperthermia. That's what I thought. And there are 2 current review articles quite recently published. And I was pretty surprised about the number of trials that are ongoing, but if you have a look at it, it's almost, or most of the trials are on hepatocellular carcinoma, and more importantly, that's the treatment row. I will see if I touch screen functional laser. Here you see this row, that all these trials use radiofrequency ablation, so not really the kind of hyperthermia that we talk about. And only 2 trials, I think it's exactly the same trials that were on Franziska's slides, use at least capacitive hyperthermia with some kind of immunotherapy. And now my talk will be mainly about fever range whole body hyperthermia, another potential hyperthermia use. And there's plenty of preclinical data that this fever range hyperthermia can or has pleiotropic effects. It reduces tumor hypoxia too. It has various effects on the immune system. And there's one recent study, I will go a bit more in detail to this, on depressive disorders. It also has some effects on the mood. So the first trial I found is on healthy volunteers, and it's a small study, of course. What did they investigate? And they had 5 healthy volunteers, and everyone received 1 session of fever range whole body hyperthermia, and they had various blood draws before treatment, after treatment. What was really nice in this study, because usually you cannot or you don't see this in vitro, I guess, they took blood before treatment and isolated T cells, and then heated up the T cells and stimulated it with a cocktail of antibodies. And you see a 2-fold increase in interferon gamma and interleukin 2 in the heated T cells, in the in vitro heated T cells. And then they compared this to the blood they took from the participants right after whole body hyperthermia. So, and I was quite surprised that it's almost exactly the same. They also see an increase in the cytokines. And of course, this blood was not additionally heated up in vitro, it was ex vitro. So it's quite surprising in my opinion. They also saw an increase in the fluidity of the T cells, and here in this slide you see also a marked increase of antigen-specific interferon gamma excretion. So that's one of these small studies that used whole body hyperthermia, and then there's another study in cancer patients. This trial investigated 1 session of fever range whole body hyperthermia before colorectal surgery. It was a randomized trial too, but with only few patients, of course. 9 patients received hyperthermia, and 9 patients received standard of care without hyperthermia. And what did the authors do? They also investigated longitudinal blood examinations before treatment, right after hyperthermia, and then at day 1, 2, and 5 after surgery. And what you can see here, Udo Geipel already mentioned HSP70. They also investigated HSP90 and TNF-alpha, and you see variations in different heat shock proteins and cytokines in the blood of patients. But of course, everyone who works with cytokines knows that the variability is extremely high. So now that's also quite interesting. There's one randomized trial on depressive disorders, and it's a trial with, I think, 35 patients, and they randomized patients to sham whole body hyperthermia or fever range hyperthermia, and had a marked and prolonged antidepressive effect in patients in the whole body hyperthermia arm. That was quite surprising, and actually there are many trials ongoing for depressive disorders that investigate whole body hyperthermia. And the authors, they had the idea that this mode of action of this fever range hyperthermia might be by an anti-inflammatory effect. And they postulated that especially interleukin-6, which plays some role in depression, should probably be decreased after fever range hyperthermia. But what they observed is the exact opposite, that interleukin-6 immediately after fever range hyperthermia was elevated. And what's even more surprising, in my opinion, they did some tests. As you can see, the blue points here, these are the sham hyperthermia patients, and these are the fever range hyperthermia patients. And the sham patients, they also were in heated cabins, so that they could not really know if they received treatment or not. That's probably really important in a study that investigates depressive disorders. The patients don't know if they receive treatment or not. But as you can see, this sham treatment also led to an elevation of body core temperature in some of these patients, like this one and this one. The elevation was even more marked than in the interventional arm. And then the authors looked for the interleukin-6 in the blood after fever range hyperthermia, and there seems to be a relatively nice correlation, given the high variability of these interleukins, between the interleukin-6 and the body core temperature. And now, our own research, we have 2 trials with fever range hyperthermia. One phase 1 trial with recurrent head and neck squamous cell carcinoma patients, all HPV negative and all with recurrence after high dose radiotherapy, usually definitive radiotherapy. The primary hypothesis of this trial was that the addition of fever range hyperthermia will lead to a decrease of tumor hypoxia. And we know from a large meta-analysis together with Jens Overgaard and Michael Baumann that the prevalence of hypoxia in primary head and neck tumors is a bit more than 50%. And there's one small paper with few patients that reported that in recurrent disease after radiotherapy, hypoxia might be even more prevalent. What we observed in this trial is there's no hypoxia in these recurrent head and neck tumors, at least not measurable by F-MISO PET, the standard hypoxia PET, let's say, put it like this. As you can see, you see only noise here, although we included pretty large tumors, as you can see in the FDG PET and MRI. But what we observed in this trial it's of course highly explorative, I have to say this, or I cannot pronounce this enough, that patients who received at least 4 cycles of fever range whole body hyperthermia at least seemed to perform maybe better, at least not worse. And because everyone who treats HPV negative recurrent head and neck cancer patients knows that it can be a bit difficult to have therapeutic adherence and to have good compliance. So now we started a basket trial with several different tumor types and several different treatment types, and all received randomization between standard of care and standard of care plus additional fever range whole body hyperthermia. And of course, now it gets extremely difficult to compare these groups. So the primary endpoint in this case is a reduction in circulating tumor cells 3 months after a start of treatment or after randomization, because there's pretty good evidence that these circulating tumor cells can be used as a surrogate marker for outcome, and we use the delta of the circulating tumor cells. So let's see. And this is a nice collaboration with the group of Professor Multov in Munich, who does all the research on circulating tumor cells, and with Professor Geipel from Erlangen, who does with his group the immune phenotyping of the blood draws. We screened 39 patients in a bit more than 1 year, and 16 patients have been randomized so far. We expected that kind of screening to trial entering ratio because it's of course a bit time-consuming intervention too. And at the moment, 6 patients have been randomized to standard of care and 10 to fever range whole body hyperthermia. And I now will present you the really exploratory evaluation of the first 5 patients, the immune phenotyping data from Professor Geipel and his team. 3 patients have been treated with standard of care and 2 received additional whole body hyperthermia. And we looked at the delta values of several immune subsets, first of all. So here's always standard of care and fever range whole body hyperthermia. You see an increase in natural killer cells, and you also see an increased activated NK4 positive natural killer cells in the fever range whole body hyperthermia arm. And at the same time, you see an increase, around 2-fold increase of activated HLA-DR positive T cells, and also an increase in PD-1 positive T cells. But of course, it's not, also we need much more patients, and we also have to look at the subgroups of every tumor type to really have meaningful conclusions. But in my opinion, this is at least really promising. So there are some preliminary data that hyperthermia, or in this case, fever range whole body hyperthermia, does influence the immune system. But of course, there are multiple alterations, and the same as I showed for the depressive disorder trial is, of course, it's not always that clear if it's beneficial or not. Like for the interleukin-6, they really thought that this should decrease, and it increased, but at the same time, the increase in interleukin-6 was associated with a better antidepressive effect. So I think even in tumor immunology, we cannot be that sure about each mode of action of these interleukins. And the same as for local hyperthermia, and Professor Creuset showed it quite nicely. There's good data for radiotherapy, but for whole body hyperthermia, we have absolutely no clue, I have to admit, about the needed temperature, about cycles, about timing. This is really quite open. Okay, so thank you very much for your attention, and I'm happy to discuss this later.